All right, you guys seeing this okay? All right, I'm going to shut my door in case there's some noise out here. All right, quick topic in the EMS world, ventilation practices and pitfalls in cardiac arrest. This is a much neglected area, and it's gone through a lot of change in the prevailing dogma over the years in cardiac arrest for sure. So hope always springs eternal. This crematorium was in the newspaper for getting its first defibrillator. So I don't know how well that's working out, but there are a couple of people who work there who might go into cardiac arrest, might benefit them. But we're going to talk about the kiss of life, so to speak. That was one of the first monikers for mouth-to-mouth resuscitation. We're not going to talk specifically about mouth-to-mouth because when EMS arrives, they don't do mouth-to-mouth. And the short story on compressions plus ventilations is that on average, when dispatch asks people to do compression-only CPR, they are more compliant, surprise, surprise, than when they're asked to seal their lips over someone and give them 30-2 ventilations. And on average, they do better in terms of survival with chest compression only instructions from the dispatch center. That, though, is not universal. If patients have a respiratory cause of their arrest, they're doing worse. So it sort of depends on the mix of causes in your community for cardiac arrest and how often you have pediatric and adolescent causes of arrest, which are more likely to be hypoxic in nature and not cardiac in nature. I think I mentioned this before. The word counter shock comes from early CPR research that was done at Johns Hopkins University by the Department of Engineering. So it was doctors and engineers that figured out that that rediscovered chest compressions. There's some indication that it may have been known a little bit before, but they had a grant from the power companies to figure out how to treat patients or linesmen who touch live wires and get electrocuted, like in this picture, and figuring out how to terminate what was often ventricular fibrillation required a counter shock, and that was to counter the initial shock they got from the live wire on the line. So that's where that word comes from. Of course, it's a very rare cause of cardiac arrest these days. There's a lot more safety. We did have a 17-year-old, maybe 4 or 5 years ago, that was working with a tree cutting crew, and he was maneuvering a scoop around, touched the live wire, and electricity arced all the way through the scoop and down to him, knocked him back and put him into ventricular fibrillation, blew his shoes off. He had some crispy toes. So it's not, you never see it, it's just not very common. The key takeaways I'll give you right away, and we may not get to all of this, but the current data suggests that 30-2 compression to ventilation ratio appears superior to asynchronous bag mask ventilation during the BLS phase of resuscitation. Now, some of you were EMTs and may have done bag mask ventilation. But the second point is when you look carefully at monitor defibrillator data, a high number of BVM ventilations fail to produce chest rise and are ineffective. These are probably squeaking out around the mouth. Third, blood oxygen levels are a critical determinant of neurologic outcome. So in critical care and emergency medicine, a lot of times we do retrospective studies and we notice differences between patient populations. And we hypothesize that maybe if we corrected for those differences, outcomes would be better. One of those recently was the PaO2. Once a post-arrest patient hits the emergency department and is admitted to the ICU, what sort of PaO2 should we target? Should we target a lower PaO2? It seems that a lot of observational data suggests high PaO2 is associated with worse outcomes. Well, that study was just done in the New England Journal of Medicine. There was no difference in outcomes for patients targeting their PaO2. So a lot of times we're chasing shadows with this stuff, but some of this data I think is very viable. There's probably a huge source of variability from the ventilation strategy. We just are kind of blind to it right now. And then there are some new technologies like mechanical ventilators and ventilation meters that might help standardize this during cardiac arrest. In cardiac arrest, your choice of airway is going to be a vote for a particular form of ventilation and its efficacy. As I mentioned, BVM can be very ineffective if there's not a tight seal, if you don't have two providers, so that one is providing a good seal and the other one is performing the BVM. But there are also costs to other ventilation strategies. Endotracheal intubation is often associated with hyperventilation, which can be bad for a patient that you're trying to manage with tenuous hemodynamics during CPR. So there are a bunch of recognized factors for neurologic survival, whether the arrest was witnessed, the initial rhythm, et cetera. All those are very well known. What is hidden from us are the ventilation strategy, things like the tidal volume that's delivered and the ventilation rate, which make up the minute ventilation, PaO2 and PaCO2, which we don't have access to. We do have some end-tidal CO2 that gives us a little idea of the potential floor of the PaCO2. But most of this is hidden from us, and we'll take some time to figure out. There's big between system variation in the ventilation practice, all the way from on the left, no positive pressure ventilation, as has been done in Arizona, which is passive ventilation during the initial phase of CPR, and all the way up to observed hyperventilation from asynchronous ventilation. And then when you look at defibrillator data, you also see there's within patient variation in ventilation practice. This is actual defibrillator data from a Salt Lake City fire, cardiac arrest. You can see the end-tidal CO2 in ventilation is kind of all over the place. Starts close to 0 here, goes up to a rate of 40, down to 20, down to 0 for a while, and back up. So that's probably contributing to outcomes. We just don't know exactly how. So it'd be nice to standardize ventilation a little bit more, just so we can understand what works the best and what doesn't. And the general dogma is that ventilation should match perfusion. So we probably don't need to over-ventilate patients. We do want to provide them with critical oxygen, but we can probably ventilate less than we need to because perfusion is so low during CPR. Anybody know what the approximate cardiac output is during closed chest compressions? It does change over time for sure, but kind of the average that's been cited. Anybody know? Any guesses? Resting cardiac output. See in the chat, 15% of normal. Yeah, that's kind of the lower end, somewhere between 15 and 30%. So it's definitely way below resting cardiac output. Is it meeting the demands of the body? Well, it may at first, but over time, the wheels come off CPR in terms of blood circulation for probably various reasons. Ribs crack. You may develop microclots. We don't totally understand the process, but if you look at carotid blood flow in animal models, it just goes down over time over the course of 20 or 30 minutes of resuscitation because blood's just not moving like it should. But across that entire period, it's somewhere between 15, 25, 30%, somewhere around there. So what is your local EMS system's initial approach to ventilation in cardiac arrest? Is it passive ventilation, 30-2 ventilation, asynchronous ventilations? Again, this is the beginning of the resuscitation, or is it some other approach? For Salt Lake City, it's 30-2 ventilation. And I'll talk about why we've arrived at that. Largely comes from this trial and subsequent analyses of trial data. So this was a trial of continuous versus interrupted chest compressions during CPR, but this is really during the BLS phase. Do you provide 30-2, or do you do asynchronous bag mask ventilation during the initial phase? What is the initial phase? On average, this was 13 minutes of the resuscitation prior to advanced airway placement. So it's a big chunk. If you consider the average resuscitation temp is about 20 minutes, this is the majority of the resuscitation attempt in terms of ventilation management. So the real question is, what matters more? Is it pausing CPR in order to give full tidal volume breaths, or trying to squeak breaths in during chest compressions? On the left side, we maybe get better ventilation quality. On the right, we probably get better chest compression fraction. We don't violate the rule of not stopping CPR unnecessarily and can just get BVM. So the headline outcome was similar in the intention to treat analysis. When they looked at a per protocol basis, 30-2 demonstrated a 1.2% improved survival. Now they did subsequent analysis and found when they looked carefully at defibrillator data to see, hey, were there pauses in the CPR corresponding to 30-2? They saw a much bigger survival benefit by treatment received. So if you crossed over, this on the left side was the group assigned to continuous chest compressions. If they said, you know what, screw it, we're going to do 30 to 2, or they got confused and did 30 to 2, there was much better survival, about a 4% difference in that group. In the group assigned to 30 to 2, if they said, no, you know, we're going to do continuous chest compressions, you can see that survival was lower, getting closer to the, did they do CCC? So their survival estimates, when they looked at the treatment received, suggested there was a bigger benefit hiding under there. It was just that paramedics and EMTs particularly found it harder to do 30 to 2 CPR than to do continuous chest compressions with asynchronous ventilations. So the ILCOR guidelines looked at all this and said, we suggest BLS do 30 to 2. There's weak recommendation, very low quality of evidence. Again, this is post hoc analysis, so take it for what it's worth, but they also suggest mouth-to-mouth or BVM give approximately 600 mLs over 1 second to achieve chest rise. I'm not sure what mouth-to-mouth can achieve. 600 mLs, I guess you could do, I don't know. That seems like a lot, but that is what they recommend for each tidal volume. Of course, very few people are measuring the tidal volume that's delivered. It's just, it doesn't show out as a readout on your bag mask device for sure, but there are some newer technologies that can give you some info on that. So again, I mentioned choice of airway is going to affect ventilation efficacy. In Salt Lake City, you've probably seen the iGel on the left here. It's a supraglottic airway that can be inserted without pausing CPR. And for reasons that will become apparent, we actually have a BLS provider variants for them to put in the iGel during the BLS phase and do 30 to 2 ventilation with the iGel instead of BVM. So for airway, the recommendations by ILCOR are bag mask ventilation or an advanced airway. They suggest supraglottic airway in settings with a low tracheal intubation success rate. They don't define exactly what that is. First pass success with intubation in Salt Lake City is pretty normal, around 80%. And then they say if an advanced airway is used, we suggest a supraglottic airway or tracheal intubation in the settings with high tracheal intubation success rate. So they're sort of agnostic after the PART trial. But as I mentioned, BVM has more skill associated with it than ventilating through an endotracheal tube. Once an endotracheal tube is in, you don't require typically 2 hands once the airway is secured. But this is really the way to perform adequate ventilation. This study came out of Texas, and they've not only taken a look at defibrillator data to see when the pauses are during this trial, the continuous versus 30 to 2, but they also looked at whether chest rise occurred when you delivered the breaths. And they can tell this based on changes in what's called thoracic impedance or resistance to current. Those patches that you put on a patient are continuously measuring the resistance to current through the chest. And with the Zoll defibrillators, it adjusts the amount of current delivered based on its measurement of the resistance. But you can also use that to see changes in resistance as the chest inflates and deflates. As the chest inflates, you get a decline in, you get an increase in resistance or impedance, and it goes down as you exhale. So they can actually measure this way whether breaths were delivered during those pauses in chest compressions. You can see that here, the changes in thoracic impedance with chest compressions occurring and then the 30 to 2 pauses. In this case that they highlighted in their paper, there was no visible change in thoracic impedance, which is associated with basically no breaths being delivered. So this is another way to drill down on the data and see are they really getting breaths in, or are they ineffective? Is the air basically going out the side and not going into the patient? And there's a huge difference in survival when they classified it based on whether 50% of the breaths of the pauses had measurable breaths given versus less than 50%. So all of this is to say that ventilation and oxygenation during the first 13 minutes appears to be critical for survival, and delivering oxygen to a patient has a big effect on outcomes that's unmeasured in classical epidemiology. We don't have that data typically as we look at survival. So their conclusion was that lung inflation often occurs infrequently during 30 to 2 CPR. I think I put the numbers in here. So the majority of cases of 30-2 had less than 50% of pauses with breaths, while 136 did. So again, it points to how hard it can be using bag mask ventilation to deliver effective breaths, even when you're doing 30-2 CPR. So the bottom line here, 30-2 saves lives, but only when the breaths are delivered. It's harder to do, but worth figuring out what to do. So what we do in Salt Lake City is deliver the breaths with an iGel. Now, once the iGel is in, shouldn't you do asynchronous ventilations? I don't know. That's another trial waiting to be done, but we're doing 30-2 with the iGel during the BLS phase in order to make sure we're getting good chest rise and breaths delivered. Even with the iGel, sometimes that fails. Sometimes you don't get good chest rise, but that's our approach. So on the other end of the spectrum is hyperventilation, which there's a classic study from 2004 that was done in Milwaukee, and it was called Hyperventilation Induced Hypotension during CPR. It was accompanied with a pig study to kind of model what they were seeing in the field, but they were seeing hyperventilation very frequently in the majority of cases in which EMTs and paramedics were delivering breaths. And this is something in the animal model that causes decreased venous return to the heart, decreased left ventricular ejection, increased intrathoracic pressure. And as you drive down PaCO2, you get reduced cerebral blood flow, ultimately making outcomes worse. So this was 2004 when they looked at a recent study, the PART trial, comparing ventilation with the, I think it was the King LT was the supraglottic of choice versus endotracheal intubation. There was better outcomes in patients who got the King LT than endotracheal intubation in this multi-center trial. Anyway, they looked closely to see using capnography, whether there was hyper or hypoventilation and how often it occurred. So hypoventilation, less than 6 per minute, was seen in 11% of cases in which they placed the airway. And this was associated with lower hospital survival. Hyperventilation, which they broadly defined as more than 12 per minute, occurred only 2% of the time. So it was much less common. I think the teaching has gone through to paramedics not to hyperventilate patients. But this was actually associated with improved survival when it was mild, somewhere between 13 and 16. So all this is to say, we don't know the ventilation rate that is appropriate once an advanced airway is placed, but it's probably higher than 10 per minute. We'll see. We kind of need all this nailed down with ventilator studies, probably. The problem is you want to avoid breath stacking and basically filling up the chest with too much air. So high ventilation rate, excessive tidal volume, prolonged breath delivery time, decreased expiratory time, and adding PEEP are probably all areas where you may run into more excessive ventilation. And so the ILCOR guidelines are, once an airway is placed, give 10 breaths per minute for adults, 20 to 30 breaths per minute for infants and children. And that may get revised at some point because it may be that slightly higher ventilatory rate is not only tolerable, but associated with better survival. So on the other end of the spectrum, we've got no positive pressure ventilation. This is an approach popularized in Arizona, where they said, you know what? Instead of hyperventilating patients, we're not going to ventilate them at all at the beginning of the resuscitation, at least for the first, I think they did like 3 to 4 cycles of CPR with no ventilation. And they reported the results in JAMA. I forget the year of this, but it's been a little while now. The study was performed between 2005 and 2007. And they basically improved their survival from a very low survival, lower than average, to an average survival. So it was like 3% to 6%. So it's hard to know exactly what to make of this, but a couple interpretations are that passive ventilation is always better than positive pressure ventilation for cardiac arrest, regardless of the practice patterns that exist in the community. Or passive ventilation is simply better than the prior practice of hyperventilating patients with prolonged CPR pauses due to advanced airway insertion. It's hard to know because with cardiac arrest trials, it's always very important what's the control side. What are you comparing it to exactly? We know from multiple studies that you need about 250 mLs to get gas exchange. So when people talked about, well, you can just passively ventilate someone, you're really not achieving, you're mostly achieving dead space ventilation by allowing the CPR and an open airway to ventilate the patient. You need more than that for gas exchange. You get about 156 mLs with an advanced airway, and less with, just kind of opening the airway with an oral or NP airway. So passive ventilation, I think of as mostly deferred ventilation. Let's not ventilate the patient. And who's the target really that might do better? It's probably the witness shockable group, which went down suddenly. They didn't strangulate, they didn't overdose and have a hypoxic arrest. That's 12% of the overall population is witnessed plus shockable. So it's a small proportion. They're the most survivable though. So all this is to say it's a little confusing whether passive ventilation is really beneficial or it was just a way of stopping some poor practices that were going on in Arizona. In animal studies, it looks like it just makes things worse overall. You get hypoxic pulmonary vasoconstriction, some decrease in cardiac output. Every patient that is getting CPR has development of dependent atelectasis during the CPR. But there are some adjuncts that might help right now. So the size of the bag may matter. There are many advocates for using a pediatric bag for adult ventilation during cardiac arrest because you can't give too much tidal volume from a bag for pediatrics, like the 500 ml bag. You could pretty much empty. That wouldn't be quite 600 mLs, but would be pretty close. You can use a metronome for ventilation. And then there's some real-time monitoring device, including on the Zoll monitors. They have a smart BVM that actually gives you the tidal volume delivered and the rate. So that may help improve the consistency of ventilations, even though we're still a little bit in the dark on all of this. You can see evidence of the ventilation rate here. During CPR, you can see the end-tidal waveform is kind of broken up. So the last question I'll deal with really quickly is too much oxygen a bad thing during cardiac arrest? And this is where dogma has shifted over time. So initially, you had Peter Saffer from the University of Pittsburgh, who was a pioneer in cardiac arrest research and did a lot of mouth-to-mouth resuscitation work experimentally, and was a very big proponent of the ventilation component of CPR. After his death, things sort of switched to let's approach the arrest with more emphasis on compressions and not worry so much about the ventilation strategy. And so you had the entry of the CAB approach to cardiac arrest, circulation, then airway and breathing. And you had groups like the group in Arizona saying, hey, look, passive ventilation works better than the usual approach of intubating the patient and giving them oxygen. A couple of studies, though, have looked at the correlation between intra-arrest arterial blood gas and survival. One of them was a pre-hospital one, which, as you can imagine, is very difficult to do. You have physicians on scene, though, in Austria, and they can run serial blood gases during the resuscitation to get some of this data. And they basically saw a nice correlation between the higher the PaO2 and the better the outcome. The highest group was greater than 300 millimeters of mercury, which we consider hyperoxia, but that group had the highest survival, highest ROSC. So oxygen is a life-saving medication during CPR, and there's no evidence that we're making the patient worse by over-oxygenating a patient during cardiac arrest. It's an area where there's a lot of conflicting data, and as I mentioned, the post-arrest data just came out that there's really no difference in outcomes in terms of targeting a PaO2 post-arrest. There's another one from in-hospital cardiac arrest, which is a little easier to do, but the same finding: higher SpO2, higher survival, and return of spontaneous circulation. I should say higher PaO2. So they recommend giving oxygen at a concentration of over 40%. We give 100% at a flow of 10 to 12 liters per minute. Finally, ventilators during cardiac arrest. These are becoming, like ultrasound, cheaper, more widely available. The Zoll one is on the right. On the left is one that we've been evaluating. It's been by a German manufacturer called Weinmann, and is very easy because you just dial in one setting and you're ready to go. Like mechanical CPR, it's going to free up hands and provide regularization of the ventilation and oxygenation, and may improve survival. We just don't know. We don't know if what we dial it into is the right settings, though. So ILCOR's recommendation is we don't know if there's not enough evidence to know if manual ventilation during resuscitation is a good thing, but it does standardize it and avoid many of the pitfalls. So, and in the end, there's a lot we don't know. There's a lot to learn about ventilation, and this is for a cardiac arrest researcher, this is probably what I would focus on as a new resuscitation researcher, is figuring out some of this stuff will probably make a big difference in outcomes for cardiac arrest. It's the hidden variable, so to speak. And now quickly going to the future, there is the same company, Weinmann, from Germany, has an approved ventilator in the EU states that does chest compression synchronized ventilation. So this is a novel ventilation strategy where the chest compression triggers a breath. And so when you're pushing down, it gives a small tidal volume breath with each compression. So that's 100 breaths per minute, but they're small tidal volume. And the minute ventilation works out to work pretty well in animal studies. The PaO2 stays higher longer using this ventilation strategy. So it kind of shows there's a lot we don't know. It's not currently available in the US, but very interesting approach. So again, these are the key takeaways. 30-2 is looking good. BVM is fraught with complications and ineffective chest rise being the number one problem with it. Blood oxygen levels are, to the best of our knowledge, a critical determinant of neurologic outcomes, so don't hold back on oxygenation during the arrest. And then we've got a bunch of these hidden variables in ventilation during cardiac arrest that will take some time to figure out. So with that, I am done. I will stop share. Any thoughts on that? I had to cruise through it pretty fast, but there's probably a little time for discussion.
Scott, do you know of any studies that are looking at actually, controlling the oxygen delivery? Because the PaO2 could just be a, strong surrogate for high quality CPR delivery.
Well, the